Get started. Welcome, everyone. We're just giving a moment as people filter in. All right, we are a couple of minutes past the hour, so we'll go ahead and get started. Emily, if you would go to the next slide, please. Welcome, everybody. I hope that you have found yourself in the correct place. This is the meeting called Advancing Measurement of the Scale and Reach of HIPs for community health workers and pharmacies and drug shops. Next slide, please. My name is Trinity Zan. I will be your overall facilitator and MC for today. I am the Deputy Director for the Research for Scalable Solutions project, focused on research utilization, and I'm based at FHI 360 in North Carolina in the United States. Next slide, please. I wanted to give you a quick overview of today's meeting. We will excuse me, have a packed agenda, and I'll go through that in just a second. But to situate this is part of a two-day meeting. We had a meeting yesterday, and now we have a meeting today with very similar content and similar objective, the objective being to identify how to improve routine monitoring of scale and reach of HIPs through national and program information systems. Yesterday, we were focused on two HIPs, immediate postpartum family planning and post-abortion family planning. And today, we have two new HIPs, community health workers and pharmacies and drug shops. And the outputs for both of these days is to generate considerations and recommendations for strengthened monitoring of these HIPs. Before I go through the agenda, though, we have a couple of polls that we want to launch just to see who's in the room and to identify how many of you may have been with us yesterday. So the first poll is asking you where you're connecting from. Are you in North and Central America and the Caribbean? Are you in South America, Europe, Africa, or Asia and Asia Pacific? So if you would just choose your region and hit submit, we will get a sense of the geography or the geographic diversity today. And we'll just give a moment for that. And Sarah, when you feel like we have a good number of responses, feel free to show us. Very nice. All right, a little less than half from North and Central America and the Caribbean, and a really strong showing from Africa and representation from other regions. So thank you for that. Now we'll ask another question. Which type of organization do you primarily represent? Are you associated with a Ministry of Health, with a donor, with an international NGO, maybe a national or local NGO, or some other type of organization? So we'll just take a moment for that. And again, Sarah, when you feel like we have a good number, let us have a look. Okay, again, a little less than half associated with international NGOs and representation across these other groups. I'm really excited about this 31% other, so I'll be looking in the chat to see what that may represent. And finally, as I mentioned, we had a two-part meeting. One part took place yesterday. And so the third question is whether you participated in the previous day's session yesterday on immediate postpartum family planning and post-abortion family planning. Just curious to see how many of you were with us yesterday. And it is very fine if you were not. All right. Okay, 61% were with us, but that's a good 39% of you who were not. So for those who were with us, We are following a similar structure for our agenda, but it is new content, so I hope it will be as exciting and stimulating as yesterday. So our agenda, we're doing the welcome and overview and framing now. We'll then have some opening remarks, followed by 2 presentations that summarize the indicator and data landscape for these 2 high impact practices. Then we're very lucky to listen to some spotlight presentations of experiences monitoring these 2 HIPs in 2 different countries, along with some discussant reactions to those. And then we get to the breakout group discussions. And this is really the heart of today's meeting, where we hope people will be able to come together, talk with each other, and share thoughts and perspectives and experiences, and really come out with those considerations or recommendations that can be carried forward. So we'll report out from those, and then we will close. So next slide, please. Before we get too much farther in, I want to just acknowledge all of the organizations who have been a part of making this webinar series possible. You see their logos here. It's been a highly collaborative effort, inclusive of many implementing partners and donors. And then on the next slide, in particular, we put together a planning committee made up of these many individuals to whom we are very grateful for having spent time and energy planning what we hope is a very interesting and interactive session today. All right, next slide, please. So just to do a little bit of framing so that we're all in the same headspace as we move into these presentations and discussions, we are really anchored today around discussing 2 specific high impact practices. And I think many of you are familiar with the HIP initiative. It's been around for about 14 years. And what has been the main focus of the product or focus of the HIP initiative is developing a set of evidence-based practices vetted by experts against specific criteria, primarily looking at impact on contraceptive uptake, but there are other outcomes that are examined. And then synthesizing that information into easy to use formats, inclusive of the HIP briefs and now a range of other products, including strategic planning guides and other references. Next slide, please. So among those high impact practices, there are multiple categories, the largest of which I think is service delivery. And within those service delivery HIPs, we find these 2 HIPs. So we wanted to just share the definitions and a few kind of related points of consideration. So for community health workers, the definition, as you see on the slide, really emphasizes having a cadre of health worker that is based in the community, chosen from the community, but linked to the health system. It's important to note that that terminology, community health worker, may not be what is used in every country or context. It could be that there is a cadre based in the community, chosen from the community, and linked into the health system that has a very different name. And so just for fun, I'd love to ask you all in the chat to go ahead and put whatever the community health worker cadre may be called in your country or program, and we'll be able to see that. But nonetheless, meeting those criteria, they would be considered this HIP. It is also possible that a country has organized as part of the health system a different approach, and so perhaps a cadre has the name community health worker, but may be primarily based in a facility as opposed to out in the community. So there is a lot of maybe wiggle room in the terminology, and we just wanted to be clear that for today's purposes, we are using the definition from the HIP brief, which again emphasizes a linkage into the health system, but being based primarily out in communities. For pharmacies and drug shops, again, you'll see the definition there. Again, these may have other names depending on the context, but generally private sector locations that are providing family planning information and services. Here we can think about the fact that there may be processes and procedures in countries to license or accredit these types of facilities to provide family planning information and services. So there may be some that are licensed or accredited and some that aren't. So again, when you dig deeper into the HIP briefs, you're able to sort of see what the criteria are for meeting that. But we are most likely focused on those that that are licensed and accredited, although not always. And one other thing to just note is that for those of you who were here yesterday with us, those two HIPs, immediate postpartum family planning and post-abortion family planning, have a long history of discussion on measurement and actually have some globally recommended indicators. And we spent time talking about those and how they might be adjusted. In this context today, these two HIPs do not have the same type of globally recommended indicators. So our discussion here is a little bit more open and invites more input into what should be considered the recommended indicators. I will note that in the Pharmacies and Drug Shops HIP brief, there are a few indicators that are included. They are a bit more targeted to surveys than to routine health information systems. So again, a little bit of a different context from what we're talking about today. Okay, so hopefully that provides a little bit of context and framing for us as we move in to the rest of the day. Next slide, please. I'd like to now hand it over to our colleague Olenike Adedeji, who's a family planning program specialist at UNFPA, who will provide us with some opening remarks. Over to you, Nike.
Thank you so much, Trinity. And good morning, good afternoon, or good evening, wherever you may be in the world. As you've heard, my name is Olenike Adedeji. I work for UNFPA, and I'm very glad to be here today and also yesterday, and to be part of this work on advancing measurements for high-impact practices. I'll be speaking on behalf of UNFPA today to tell you about, can we go to the next slide? Just about what is it that UNFPA is committed to in terms of this piece of work. So first of all, UNFPA is committed to what we call the 3 zeros. And I start by saying that the overall UNFPA mandate is based on the program of action of the International Conference on Population and Development, ICPD. And this drives our current UNFPA strategic plan 2002 to 2005. But we know, reflecting on the last 30 years of ICPD, we recognize that the world has changed significantly, and especially in the last decade. And this has impacted significantly on the work globally and in countries around family planning. So one of the priorities that we have identified is reaching marginalized populations with family planning and SRH services. And UNFPA is embarking on doing this in this current strategic plan by calling for what we call the 3 transformative results: ending unmet need for family planning, ending preventable maternal deaths, and ending gender-based violence and all harmful practices. Now, in terms of family planning, we also are thinking about the scale of the challenge. Evidence shows that half of all pregnancies are unintended. This represents a global failure to uphold a fundamental human right, which is the ability to decide whether and when to become pregnant. And we have especially let down adolescents who have the highest unmet need for modern contraception. 1 in 3 girls give birth before the age of 20, and nearly half of these girls are under 18, which means they're still children themselves. However, unmet need for family planning has declined globally from 9.1% in 2010 to 8.5% in 2002, with the highest unmet need observed in sub-Saharan Africa at 16.3 as at 2002. Access to sexual and reproductive health, including family planning, is central to one's ability to exercise the right to bodily autonomy, agency, and choice. We can and must work together to accelerate family planning progress across Africa and all of the world so that women and girls can exercise their reproductive agency and utilize contraceptives to choose whether, when, and with whom to bear children. Through this choice, girls can stay in school, invest in their own human capital and families, increasing the resilience of the communities and economies. So to this end, UNFPA launched its family planning strategy, the revised family planning strategy in 2022, which is tagged Expanding Choices, Ensuring Rights in a Diverse and Changing World. And this presents a forward-looking approach to meeting the unmet need for family planning in diverse situations and settings, and anticipating emerging issues and trends. It embraces a broader and more inclusive conceptualization of family planning and places even greater emphasis on gender equality and human rights. And on that slide, you will see the 8 priorities that have been outlined, and you will see that strengthening data is actually one of them. And that's one of the reasons why we have been involved in this piece of work around advancing measurements for high impact practices. So in terms of measurement, we can be idealistic about our dreams and goals about what kind of world we desire for the 8 billion population we currently have. But what we need to do is to be realistic and practical about measurements so that we can track progress and take corrective action when needed. So I encourage you today, as you engage in these discussions, to think ambitiously, but also think realistically. And we have been working on a number of other issues around the HIPs. One of it is about the bottleneck analysis and other measurements around the HIPs. And I'm hoping that at some time in the near future, we will be able to come to you with more information about the evidence that we've gathered around measuring these high impact practices. Thank you very much to the team for this opportunity. And I look forward to the outcomes of this meeting. Thank you very much. Over. Back to you, Trinity.
Thank you, Nike. Thank you for those remarks, that information about UNFPA's commitment and interest, and also some of the reasons why measurement is so important in order to help us achieve our collective goals and objectives. Next slide, please. We'll move right into our next session, in which we'll be sharing a sense of the universe of data that's available, data and indicators that are available within health management information systems and among what partners and projects collect for scale and reach of these 2 HIPs. We have 2 wonderful speakers who will be sharing with us today. First will be Susan Pietrek, the Data for Impact Partner Lead at ICF, and she'll be followed by Aurélie Bruni, who is the other Deputy Director with me at Research for Scalable Solutions, as well as the Director for another complementary project called SMART-HIPs, and she's based at FHI 360. And I will just remind everyone, all of our speakers, to speak slowly for our interpretation. And for those of you who may not have seen the instructions, we're pasting those into the chat if you want to select a language, your preferred language. At a later point in the presentation, we will be hearing from some speakers in French and potentially in Portuguese at some point. So I encourage you to select your interpretation language and for all of us to speak slowly. And with that, I will hand it over to Susan.
Thanks, Trinity, for that introduction. Nice to be here with everybody. So I'll be sharing just a few slides about some work that was done to identify HIPs indicators. And this was work carried out by 3 different projects, which were reflected in the titles for me and orally. So the Data for Impact project, and then also the Research for Scalable Solutions, or R4S project, and then the SMART-HIPs projects. And so in this presentation, we're sort of combining what was found in the three similar exercises that these projects undertook. So next slide. So just to start with a broad overview that the D4I and SMART-HIPs R4S that conducted a similar exercise of collecting HIP indicators that partners report on. And the D4I, their work focused in Bangladesh and Tanzania, whereas for the SMART-HIPs R4S, they conducted the activity in Nepal, Nigeria, and Uganda for the community health worker HIP. And then for the pharmacy and drug shops, that was in Nigeria and Uganda. And in this presentation, we're using the term partner. And so it's important to note what we mean by partner. And for D4I, that means something very specific in terms of being USAID funded projects. And for the SMART-HIPs and R4S on that side, as you can see, partner is a little bit more expansive and includes both USAID and UNFPA funded projects, as well as NGOs, INGOs, and CBOs and that support HIPs implementation. In both cases, the way that this exercise worked was that partners filled out a spreadsheet describing the indicators they collect. From the list of indicators, duplicates were identified. And then further, a list of unique indicators was established by collapsing similar indicators that measured the same concept, despite slightly different language or different disaggregations. Next slide. On this slide, we used a funnel graphic, and that was purposeful, sort of to help convey one of the main findings from the indicator inventory exercise. Partners collected a variety of indicators that can be distilled or funneled down into a few unique indicators. Some of the indicators are common across the partners, although in many cases, the indicators are unique to only one specific partner. Next slide. This slide shows the full list of CHW deduplicated and unique indicators from the partners for the SMART-HIPs R4S, as well as the indicators collected by D4I. The D4I indicators are mapped or slotted in the most relevant place in relation to the SMART-HIPs and R4S indicators. As shared on the previous slide, the SMART-HIPs and the R4S found 14 unique indicators on CHWs, of which the D4I project shared 2 of those same unique indicators. D4I found 4 additional unique indicators that could also be considered unique. This makes the total unique indicators found by both projects to be 18 unique indicators. So next slide. This slide shows the full list of deduplicated and unique indicators for pharmacies and drug shops, collected by the SMART-HIPs and R4S project. Again, D4I did not collect pharmacy and drug shop indicators. As shared on the earlier slide, there were 16 unique indicators for PDS. And again, noting that in many cases, the indicators were unique to a single project. Next slide. A number of things were learned from this exploration of what indicators partners use for the CHW and PDS HIPs. First, indicator definitions varied. And particularly once you extend beyond the common indicator of number of US government related CHWs providing family planning information. That was a common indicator among many partners and with a pretty straightforward definition. But beyond that, there was a lot of variety. And so also there was not consistency in terms of the disaggregations that were used. The inconsistencies were generally visible through the deduplication effort. For example, note the blue box on the right. This lays out an example of how deduplicating worked. The unique indicator is number of clients who receive family planning from CHWs. Establishing that as a unique indicator came about by collapsing similar indicators that measured the same concept. These are listed as well in the blue box and noted there the illustrative submitted indicators. These are the deduplicated indicators. In addition to looking for inconsistencies in terms of language, it was also important to understand what disaggregations were being undertaken, how data flows, and how the indicators were calculated. Next slide. A second key finding is that it was generally the case across the partners that HMIS reporting is more the exception than the norm. Some of the possible reasons include that indicators are frequently not being reported into a national system are those that are primarily useful for improving HIP implementation at the program or local level. Also, some indicators are used to inform broader programmatic goals, and these can sometimes also be used to understand HIP implementation, especially when disaggregated or serving as a denominator. In the blue box on the right are some indicators from partners they use, but the partners also noted that these are not reported to the HMS. So next slide. I will end with this slide, and just to note a few summative sort of takeaways. That from the exercise, it's very clear that partners monitor HIPs and have indicators that relate to HIPs. However, it was also very clear that there's a lot of variation in terms of the indicators that partners are using. And often seemingly comparable indicators are not similarly worded, and there are not consistent definitions. In most cases, the partner data are not connected to the national system via the HMIS. So thanks so much. And I think from here, turn things over to Orly.
Okay, thank you, Susan, and good morning, good afternoon, and good evening, everyone, wherever you are joining us from today. I am delighted to be here to share with you the results from a review of HMIS tools for indicators related to community health workers and pharmacies and drug shops. And if you were with us yesterday, about 60% of you, this is very similar to the review that Deb presented for PPFP and PAFP. The HMIS is obviously a key source of information on family planning services. And the goal of this presentation is to provide insight from a few countries on the information that is currently being collected as we ease into more discussion into later today on data measurement and use. Next, please. So we conducted a review of HMIS registers and forms in 5 countries: Burkina Faso, Mozambique, Nepal, Nigeria, and Uganda. And you can see on the right-hand side the review process. We started by developing a list of all the relevant indicators across the reviewed forms. Then we mapped which indicators were collected in which country, at what level, and what disaggregations were available. And finally, we ended with a verification and validation step. Next, please. So before we get into the results, I thought it would be useful to situate the review in the context of typical data flows. There is variation across countries, so this slide is a bit generic by necessity, but there are essentially 3 main tiers. Starting at the bottom, at the community level, the community health workers, the pharmacists, the drug shop operators typically enter interactions with their clients in a register. Then some information from the registers is aggregated and put into a monthly summary form. And that's where a lot of the variation occurs in terms of the number of intermediate level across which the monthly totals may be aggregated. So for example, for community health workers, the monthly totals from the community health workers may be incorporated into the monthly summary forms from their supervising health facilities, and then the monthly forms from the facilities may be transmitted to the districts. And some of the flow is done on paper, but at some point, the monthly totals are entered into DHIS2. All the data funnels into the national HMIS, where it can be further analyzed for reports or goes into dashboards. Next. So we'll start with the results for community health workers, and then we'll move on to pharmacies and drug shops. Generally, the review is focused on the 3 categories of indicators that were most common across the forms that we reviewed: family planning counseling, family planning method provision, and family planning referrals. Next. And next again. So as Trinity noted in the framing, and many of you contributed as well in the chat, I would like to take a brief moment to acknowledge that CHWs is an umbrella term that captures different cadres in different countries. And you can see the cadres that correspond to the review here in the second column of the table. The table also shows the forms that we reviewed in each country, starting with registers that records interactions at point of service between CHWs and clients, and then summary forms. So in Burkina Faso, Nepal, and Uganda, the information from the community health workers is aggregated and it's entered into monthly summary forms by the facilities that supervise them. The systems that are covered for this, by this review for Mozambique and Nigeria are not national. They are pilots, with the countries holding further discussions on next steps currently. In Mozambique, Upscale is a digital health system strengthening platform, which includes a data entry app that feeds into DHIS2. And then in Nigeria, the Federal Ministry of Health and Social Welfare has been piloting a community HMIS for community-based distribution in collaboration with stakeholders. And that system involves individual community-level forms that are then aggregated up, and it has provisions to separate the data from the CHWs from the facility clients as the data make it up into the system. And you will hear more about this later today. Next. So let's get into the results. In this table, a cell with a Y means that the information is collected in registers. And then if the cell is also shaded in dark purple, this means that the information also goes into the monthly summary forms. So you can see here that 4 countries capture information on family planning, method provision, and referrals into registers and monthly summary forms. 2 countries capture information on counseling in the first column in the registers, and one of those records it in monthly summary forms. In Uganda, there is no official service delivery register for the VHTs, so the CHW cadre in Uganda. The VHTs use ad hoc registers and they report their data to their supporting health facility, where the information is then combined with the data from the health facility. So what it means is that the numbers for the VHT make it into the monthly total, but it is not possible to distinguish the VHT clients from the facility clients in the totals. Next, please. So here we looked at disaggregation by age, by method, and by new or returning users. So for age, 3 countries record age in registers, typically as a write-in, and Burkina Faso and Nigeria then recorded in summary forms using age categories. Methods are typically recorded in registers and reported on the summary forms. And where it is recorded in the registers, the disaggregations by new and returning users are also carried over in summary forms. Next. So finally, we looked at the specific methods being recorded, acknowledging that there is variation in the methods that CHWs are authorized to provide across countries. And you can see here that all the methods included in the registers are typically carried over to the monthly summary forms, with the exception of other in Nigeria. Next, please. So this is a summary slide showing the number of countries capturing information in registers and summary forms for each of the 3 indicators. And you'll see that 4 of the 5 countries capture information on method provision and referrals, both in the registers and in the summary forms, but that documentation of counseling in the top row is less common at both levels. The other point that's emerging from this review relates to the data flows and the extent to which, as the information goes up into the information pyramid, it can still be attributed to the CHWs. So as I noted earlier, in Burkina Faso and Nepal, the CHWs transmit their data to their supervising health facility monthly. The data is combined across all the CHWs reporting to the same facility, but it is separate from the facility clients. Whereas in Uganda, there is no separation of the VHT clients from the facility clients. So it's the entirety of the clients for the catchment area. And Mozambique and Nigeria are still in the process of making decisions for their systems, but you will hear more about what is happening in Nigeria later today. Next. And next again. So for pharmacies and drug shops, I actually only have 1 slide to show you because the landscape is different and information on pharmacies and drug shops is not integrated as much into the HMIS as it is for community health workers. What we saw in the few countries covered by the review is that there were essentially 3 main scenarios. The first one is that no data is collected, as is the case in Burkina Faso and Mozambique. The second is that data is collected and aggregated with facility data. So in Nepal, pharmacies and drug shops are not recognized as reporting units by the government. They may report data to a local facility or a municipal office, but then the data gets aggregated with the facility data. In Uganda, the system includes data from drug shop operators in the monthly summary forms from the health facilities, but similar to what we discussed for VHTs, the data of the drug shop operators and the facilities is combined. And lastly, as noted earlier, Nigeria is piloting a CHMIS, which would capture data for private sector actors at the community level. And the forms record the 3 indicators that we discussed: counseling, method provision, and referrals, and they allow some disaggregation. But again, you will hear more about that shortly. So thank you very much for your attention, and I look forward to more discussion in the breakout groups.
Thank you, Aurélie. And I forgot to mention at the beginning of the webinar that given our schedule, we don't have time for questions directly to presenters, but I invite you to put those into the chat, and as feasible, they will respond. And also to note them down for yourselves and bring those to the breakout groups. I think that these 2 presentations provided a lot of the kind of foundational information that we will use as a jumping off point in those breakout groups, including, what's happening now, where do we see that data flows and stops, and where are there opportunities to consider changes to that data flow, and which data is being captured, and particularly for pharmacies and drug shops, noting how little data integration there is, likely raises a lot of questions about challenges, but also opportunities. And so therefore, we're really excited about this next session, which in fact highlights a few examples, 2 examples of countries embarking on ways of collecting data, both from the community level in one instance and from private sector in the other instance. So really highlighting what those challenges and opportunities are. So we will first hear 2 presentations. So firstly from Brighton Muzavazi, who is a Track 20 M&E officer in Zimbabwe, and will be talking to us about private sector integration of data, private sector data. And then from Mr. Lawrence Anyanwu, who is the Director and Acting Head of the Reproductive Health Division at the Federal Ministry of Health and Social Welfare in Nigeria, talking more about that community health information management system that Aurélie mentioned. So we'll listen to both of these presentations, and then I'll be inviting 2 additional speakers to kind of react and discuss what they heard. So I'll first turn the mic over to Brighton. Brighton, I invite you to come on, and if you're able to turn your camera on.
Thank you very much, Trinity, for the introduction. I'm happy to be here to share with you our experiences in engaging the private sector reporting in the country. So the title of this presentation is From Private Sector Data Capture to Health Information Exchange. When this initiative started, the goal was to have everyone reporting through the health information system, which was there in place. But it later changed to when we recognized that the main system in the Ministry of Health, which is the DHIS2, is not the only system that collects data on family planning, but it's only one of the systems that are there. So the Health Information Exchange seeks to create an interoperability layer which enables different systems to be able to communicate to each other. Next slide. So firstly, want to know why private sector reporting is of paramount importance in Zimbabwe. This is because we have close to 1/4 of services being provided in the private sector, but 22.3% from the latest survey shows that clients are getting their services from the private sector. And most of the private sector's facilities, including pharmacies, private clinics, and private hospitals, were not reporting in the national HMIS system. And there was no information on who exactly in the private sector is providing family planning services. And on that issue, the government procures contraceptives and then sells to the private sector at a discounted rate. So the national pharmaceutical company is responsible for distributing and selling contraceptives to private pharmacies and private clinics and hospitals in the country. So by summing up all these points, there was a great need to monitor and know what exactly is happening in the private sector. And also the government is also working with the Retail Pharmacy Association, providing them training, information, and also updates on the guidelines and new information and new methods of contraception. Next slide. Yes, so there were efforts which were made to get a clear understanding of what exactly is happening in the private sector. Since 2016, there were efforts to standardize the reporting tools. There were different registers which were used in the public sector as well in the private sector. So a harmonization platform was created and one single reporting tool was generated for the country, which is being used both in the private sector and also in the public sector. Secondly, there was a mapping exercise which was conducted. This exercise was meant to see who is in the private sector who is providing contraceptive services. And the results showed that the private sector consisted of hospitals, private clinics, pharmacies, and also individual or providers like the doctors in their rooms. They were also providing contraceptives. And for the pharmacies, from this survey, it also showed that the pharmacies, there are different levels. There are big pharmacies which are like wholesalers, and those are well established. They've got a system where you can track their data. And we also have individual pharmacies who are small, and in most cases, they do not have proper systems. So a training of pharmacists and pharmacy dispenser assistant was conducted with the Ministry of Health to provide them more information and also aid them on reporting on the services they were offering. By this, the goal was to make sure that everyone will report to the Ministry of Health through the DHIS2 system. But there were some challenges that were also faced. Some of them include the extra burden of making sure that everyone reports in DHIS2. There were cost component, human resources, and also time. And also it was also creating a burden on the server in the Ministry of Health, because more space was required to ensure that everyone else feed their data into the national HMIS. Then there was this idea of creating this health information exchange, which seeks to ensure that everyone will continue using their own system, but these systems will be able to speak to each other and creating a central repository of data for both the private sector and the public sector. Next slide. So this slide is showing us different systems that are there in the country, which collects data on family planning, not only the national HMIS. We have the DHIS2 in the Ministry of Health, but there are other partners who are also providing contraceptive services in the country. They've got different systems which are well established, which they are using for collecting data. We also have the electronic health record system, which is called Impilo. It's also there, which collects patient level data. Also have systems for the logistics management information. They seek to collect data on contraceptives distributed to facilities. Then we also have the pharmacy associations, the retail pharmacies. They also have different systems which they are using to collect data. So this health information exchange was trying to balance the two, not overburdening the private sector by forcing everyone to use the DHIS2, to use the family planning register and the monthly reporting tools that are used by the ministry. But this was to make sure that different systems will be able to communicate together and also store the data. The data is now stored at a central place, and anyone with access to this health information exchange can retrieve data from different systems. Next slide, please. So this slide is showing us the general architecture of the health information exchange. And I'm not going to go into detail of the softwares that are used to create this health information exchange, but I will draw your attention on the first column. The column is showing us different systems that are there, both in the public and in the private sector, also including in the pharmacies. There are private clinics, private hospitals. They are using systems like the BAMNI, which is used to collect data. It has got client level information. Then we have the electronic health records. They are also there. And we also have the Rapid Pro and the logistics management information system. All these systems, they have data on who is accessing contraceptive services in the country. And still on the same column at the bottom there are other open sources of data which are there, like the national census, the demographic health survey. All these surveys, they have data on contraceptives. So the idea was to make sure that these systems will be able to push their data through the interoperability layer, which is on the middle there. And this now will be able to interpret data from different systems and then store that data at the central repository. And the last column there, that's where the consumers can access data from different systems. And now this has been completed and is being managed by the Ministry of Health. Anyone who wants data can request to the Ministry of Health and get access to the system. So by doing so, the service providers and the pharmacies will continue providing services and using their own system. The health information system will then pull data. The health information exchange, rather, will then pull data from different systems and convert that data into variables that can be used and that can be accessed from the different users in the data repository. Next slide. So this is my last slide, which sums everything that I've talked about. This health information exchange creates a central repository of family planning data in the country, including data from the pharmacies. Most of the pharmacies in the country, they get their contraceptives from the National Pharmaceutical Company. So the National Pharmaceutical Company is a system which is linked to the health information exchange. So all those that are procuring from the from the National Pharmaceutical Company, their data is represented in the health information exchange. Then we also have big pharmacies, which are mostly wholesalers, and they procure other contraceptives outside the country. And they've got some systems which are also linked to the health information exchange. So data on the pharmacies is now represented, and you can get a clear picture of what is happening. Mostly for the pharmacies, the indicators that we were tracking are mainly the clients that are accessing services disaggregated by method. And from there, you can go on to generate the CHWs, the couple years of protection. And this information is also very important when it is integrated with other sources in generating an indicator called the estimated modern use, which we use to create the core indicators for FP 2030 reporting using family planning estimation tool. So by getting data from the private sector and also adding data from the public sector, you can now have a complete picture on who is getting the services. And by that information, going beyond the CHWs, we can generate the estimated modern use. We can also feed that data into FPET to generate core indicators such as unmet need, demand satisfied, and modern contraceptive preference rate. So this health information exchange was built outside DHIS2. And DHIS2 is one of the systems that are also contributing data to the health information exchange. And we also have data from surveys, from population data that we can use to benchmark the data that we are getting from different systems. And this health information exchange will pull data, will store data, and make sure that the data is being retrieved by those we have access to the system. And as we are doing this, some of the challenges that we faced, one of them was to get access to different systems used by different stakeholders, different pharmacies, different facilities. And we had to engage the highest authority in the Ministry of Health to write to these partners and ensure that access is being granted. And now it has been granted. The health information exchange is almost complete, and very soon all the stakeholders will be there. But data for the pharmacies from the National Pharmaceutical Company is already there. Data from other private stakeholders is also there. I think this should be my last point. Thank you. Back to you, Trinis.
Thank you, Brighton. That was an immensely complex system that you summarized for us. So thank you for that, and exciting to know that family planning is in some ways leading that process, which, as you noted, is not often the case. I think there may be some questions for you that come up in the chat if you're able to take a look. Thank you so much. And now I'd like to hand it over to Mr. Lawrence, who will be talking about their community health management information system process. Over to you, Mr. Lawrence.
Okay. Thank you, Trinity, and good day, everyone. As has been said, Nigeria recently designed and piloted a community health management information system. And the idea is to ensure that we're able to collect and report data coming from services provided at the community level, as well as those provided by the private sector health facilities who were initially not part of the National Health Management Information System. Next, please. So between next. Between 2022 and 2023, this system was piloted. The purpose was to, like I said, facilitate the collection and reporting of community-based services data on a national scale and ensure that it reflects in the National Health Management Information System for decision making. This tool was piloted in just 9 states out of Nigeria's 36 states, but it gave an indication of the usefulness of the tool if it is rolled out on a national scale. Next. So this tool is supposed to be used by certain categories of health workers who are being integrated into the healthcare delivery system in Nigeria. Just like was said earlier, the community health workers includes a variety of health workers, and for Nigeria, we are looking at junior community health extension workers, as well as senior CHWs. We're also looking at CHWs, that's community health influencers and promoter scheme agents. We're also looking at community pharmacists. And then we're looking at proprietary and patent medicine vendors, PPMVs. There are also focal persons that have been appointed to support the management of the work of the health workers. One of this group is the community engagement focal persons. Then we have the traditional birth attendants. All of these categories of health workers provide services not just in family planning, but across the spectrum of the healthcare delivery system, and use appropriate types of the community HMIS registers to report and ensure that what they do is transmitted into the community HMIS database following the prescribed route. Next, please. So the community HMIS has a number of tools that are used to collect data on services provided for family planning, which is one of the 6 program areas that services are provided and reported on. We have the first set of document is the FP Family Planning Client Record Folder, which contains basic information on clients like the bio data of the client, the maybe if there are tests done, so they are captured there and could be referred to at any time. Then you have the community-based daily family planning register, which is used to collect information on clients seen and the services provided to them on family planning. And this is used to feed data into the monthly summary form. And you have the monthly summary from the community HMIS monthly summary form, into which data from the community-based daily FP register are transmitted. So there are 2 ways that this could be completed, this community HMIS monthly summary form. it could be completed by the individual health workers themselves. And then if they do this, the form, the completed form will now be passed through the ward focal person who is in charge of collection of health facilities that are providing family planning services in a given ward. So the health workers that are providing family planning services in that ward will fill their forms individually and then pass them through the ward focal person who in turn sends them to the local government health office for the M&E officer to now feed into the platform for community HMIS system. So the other hand, all the community-based daily family planning registers will be completed, data transmitted into the monthly form and then handed over to the ward focal person who will now summarize them into a single monthly summary form that captures all the work that has been done by the community health workers within that particular ward and send them as a single register to the local government health office from where they are transmitted into the community HMIS platform. So these are the two suggestions that have been made following the piloting. And we are still at the piloting stage. So a definitive decision has not been made on this. The other suggestion is that as the program is advancing, the implementation is advancing, we could also have the ward focal person, transmit directly to the community health management information system platform. So these are suggestions, and at the appropriate time, decisions will be made as to the best approach to take, or maybe a suite of approaches that could be taken. Next, please. So, our focus on indicators for Nigeria, we have the HMIS, the community HMIS registers being designed in a way that we're able to collect information across the three indicator areas. Under the counseling indicator, we have provisions for counseling for family planning, as well as counseling on PPFP. So this is covered. Then for the service provision itself, we have disaggregation that will give us information on new acceptors within the community. There's also provision for recording commodities given to clients in the community, as well as the age categorization. The age of clients are appropriately disaggregated. So in that situation, maybe if there's a research, the researcher will be able to know the age groups of those that have taken up family planning services, and even uploading it into the server, you also find out that this is easily going to align with what you have in the DHIS by the time the two are brought together. Then on referral, the third set of indicators, we have the various commodities referred to under referrals. So there are categories of referrals, including medical referrals for sterilization and all that. So this is comprehensively covered to show that no commodity type or no service type is ignored. All of them are prioritized. Next. So in terms of integration with the National Health Management Information System, getting the community community level service provision properly reported in the DHIS. Data elements collected and indicators reported through the community HMIS largely align with those on the NHMIS and by extension the DHIS2 platform. Secondly, the community HMIS platform currently, because we are still at the stage where we have not scaled it up across the country. So what is in place now is that the community HMIS is running as an independent system. Though the idea is to, once we are rolling out, once we are scaling up, we bring the two together so that we use one server. We enable the community health management information system server to be able to feed into the DHIS2, just like the National Health Management Information System is doing. But right now, there are two different servers, one for NHMIS, which is already feeding into the DHIS2, and then the one for Community Health Management Information System is on a separate platform. But the idea is that with time, when we fully roll out, that the two will be feeding into the DHIS2. But the good thing here is that the way the forms are completed and uploaded into the community level down to the ward where that form is coming from, as well as also to the individual health worker, community health worker that has provided that service. So it's expected that at some point when we roll out the community health management information system, that will be able to have a feed into the DHIS2, so we have a comprehensive national data that covers all levels of healthcare service delivery, including the community level. Next, please. So what are we looking up to? The first thing is that the Federal Ministry of Health, through the Department of Health Planning, Research and Statistics, should be able to convene a stakeholders meeting to further consider the report from the pilot exercise, which, like I said earlier, shows that the system is a very good one and should be scaled up across the country. So we need to call stakeholders to agree on the modality for doing this. We also need to mobilize resources, that's the Federal Ministry of Health, to support the rollout and the scale up of the system with an annual operational plan put in place to facilitate this. And then it's also important that a secure source of funding is ensured to be able to purchase and maintain a server that will serve the community HMIS and enable it to be maintained appropriately, so that its data can feed into the the DHIS2 platform, where the stakeholders, those that have interest one way or the other to use the data from Nigeria could access such and make appropriate decisions. So this is where we are. The system has been piloted and found to be useful. We are eager to take it forward so that we can begin to harvest fully the data from the community level. And this also is supported by the recently launched health sector reform agenda of the present government, where the community level healthcare delivery system recognize all these categories of health workers and also the community health management information system. So I think as we implement that initiative, it will create room for us to be able to scale up the community health management information system. Thank you, and over.
Thank you, Mr. Lawrence. Appreciate hearing about this. Another innovative opportunity to collect data from the community level, inclusive of private sector, which is interesting and relevant, obviously, for today's discussion. So now I would, if we can have the next slide, please. I would like to invite two individuals who have the current job descriptions and perspectives to really help think through what challenges and opportunities they can foresee in attempting to collect this type of data from communities, community health workers, from private sector, launching off of these two very interesting experiences in Zimbabwe and Nigeria. Rogers Kagimu, who is the M&E officer at the Ministry of Health in Uganda, and Mujani Zenin, who is the M&E officer in the Democratic Republic of Congo. So I'll ask first Rogers, and then I'll ask Zenin to just come and offer your reactions, your reflections as you think through what collecting this type of data might look like in your own country context. So Rogers, over to you first.
Thank you, Trinity, for this opportunity. And I thank the two countries that have presented. I think they have shown to us that, yes, it is possible. We can be able to pick this data. Allow me speak mostly to the presentation from Zimbabwe. I think what we note is the fact that there are lots of data and information that we need to use on top of what we routinely use that sits outside DHIS2. And surprisingly, such a kind of data is already in usable formats. But probably what could be unfortunate to the programs is the fact that we happen not to have a precise kind of measure of the body volume of this data. So for some countries that can really aspire to have health information exchange, leveraging on their digital health strategies to enable synchronizing of this data from the private to the national system, I think this is one way that we should look at.
Thank you, Rogers. Can I ask you, there's a bit of background noise with you, so I wonder if I can maybe go over to Zenin and ask for a few of his thoughts and reflections, and perhaps we can come back to you if it's able to be a bit more quiet. It was hard to hear you. So I'll go over to Zenin now. Zenin, I invite you to please share your thoughts and reflections as you consider the challenges and the opportunities for gathering data related to community health workers and from pharmacies and drug shops. Over to you.
Merci beaucoup, Trinity. J'ai beaucoup aimé la présentation de Brighton et aussi de Nigeria. Je vais faire quelques petits commentaires, beaucoup plus en termes de défis, parce que la RDC, nous avons aussi tenté de collecter les données des officines pharmaceutiques. Il faut dire que c'est encore en phase d'expérimentation. Alors, qu'est-ce que nous avons constaté? Nous avons trouvé un commun accord sur les outils qu'il faut utiliser au niveau des officines pharmaceutiques. Le premier des grands défis, c'est qu'il y a eu beaucoup de projets qui ont voulu collecter beaucoup plus de données, alors que les officines pharmaceutiques, ils travaillent beaucoup plus pour vendre les produits. Ils n'ont pas beaucoup de temps pour passer tout le temps à collecter beaucoup d'éléments de données. Et ça a été des grandes discussions pour qu'au finish, on se dise, non, au niveau des officines pharmaceutiques, nous avons besoin juste qu'on nous dise les quantités qu'ils ont reçues au cours d'une période et les quantités qu'ils ont dispensées aux clients qui sont passés s'approvisionner au niveau des officines pharmaceutiques. Donc, un des plus grands défis, c'est arriver à trouver le minimum d'éléments de données et qui ne puissent pas surcharger les prestataires des officines pharmaceutiques. Un autre grand défi auquel nous avons été butés en RDC, c'est la question de redevabilité, accountability. Parce que, contrairement au Zimbabwe, où les officines pharmaceutiques sont approvisionnées par un dépôt central national, en RDC, les officines pharmaceutiques ne sont pas approvisionnées par un dépôt central national. Donc, ce sont des pharmacies purement privées qui achètent leurs produits chez les grossistes. Donc, il n'y a pas un mécanisme d'obligation de rapporter sur les quantités qu'ils ont gérées durant une période. Et ça a été un autre grand défi auquel nous avons été confrontés. Et heureusement, par rapport à ça, nous nous sommes résolus dans un premier temps de rester dans les officines pharmaceutiques qui sont dans les réseaux. Je donne un exemple ici. Nous nous sommes dit, on part d'abord avec les officines pharmaceutiques qui sont dans les réseaux des DKT, parce qu'on peut, à travers DKT, mettre en place un mécanisme de redevabilité et surtout que ces officines pharmaceutiques s'approvisionnent auprès des DKT. Un autre défi, c'est l'instabilité du personnel. C'est vraiment privé-privé. Vous avez formé un dispensateur de soins aujourd'hui qui offre les produits, qui collecte les données. Après-demain, vous venez, on vous dit non, on l'a chassé. Il n'est plus là. Ou bien il a trouvé bon emploi ailleurs. Il est parti. Et ça nous remet à des situations où il faut constamment prévoir un mécanisme qui puisse former ceux qui vont faire le travail au niveau de la pharmacie, le travail de rapportage des données. Un autre défi qui n'est pas le moindre, c'est le circuit de rapportage. Et nous avons trouvé pas mal de difficultés dans les circuits de rapportage parce que la question, c'est est-ce que l'officine pharmaceutique, à la fin du mois, doit produire un rapport qui doit aller déposer au niveau des districts ou bien il doit produire un rapport qui doit être déposé au niveau d'un point de prestation, un établissement de soins. Les mécanismes semblent assez lourds par rapport à ça, mais je pense que nous allons trouver une solution et la solution qui prévoit actuellement, c'est beaucoup plus que les données soient saisies, encodées au niveau des officines pharmaceutiques au lieu de chercher à donner ailleurs. Un dernier défi auquel je veux faire allusion, c'est le changement d'adresse. Vous avez une officine pharmaceutique qui aujourd'hui a une localisation bien précise, mais c'était un établissement qui louait. Demain, vous venez, on vous dit non, ils ne sont plus là. Ils ont quitté, ils sont allés ailleurs. Et donc, il faut les suivre là où ils sont partis. Voilà, ça, c'est pas mal de défis auxquels nous avons été confrontés en RDC par rapport à cet exercice, cette expérimentation des rapportages des données par les pharmacies. En ce qui concerne
Zenon.
Oui.
Zenon, sorry
Yes.
to interrupt, but I think you gave us many examples of challenges, very useful. I'd like to go back over to Rogers since we didn't have as much time to hear from him. So thank you, Zenon, for raising those challenges related to motivation for collecting data, but also to those processes, some of the real challenges in finding private sector entities and getting that data flow. So Rogers, I'll come back to you. One or two additional reflections or remarks from you.
Yeah, thank you, Trinity. I hope I'm a bit clear now.
Yes, it sounds better. Thank you.
Great. I think we need to underscore the fact that there's a lot of information we need to use on top of what we use that sits outside DHIS2. And what is very unfortunate is the fact that we do not have a precise measure of its product and probably the volumes. So countries that can try to achieve what Zimbabwe has achieved could consider looking at probably the health information exchange platforms that might exist or spelled out in their digital health strategies. In this, we are likely to see that private data can easily be synced into the national office systems. Of course, for a case of Uganda, for example, this might not need a lot of resources, but instead that assertiveness from the program to make sure that the private sector data comes through. Why that assertiveness is the fact that private sector by nature doesn't want to report because has not appreciated the relevance in reporting, and also the printing of the forms is really very costly. And again, compiling these reports is such a cumbersome exercise. So if you don't give them incentives, then they will not report. And once the incentives go away, you realize that the reports will tend to stop. So therefore, a government-led partnership with the private sector, I think it will be a better way to make sure that data comes through from the private sector. What Zimbabwe has shared, I believe this is something that can be replicated in quite many countries. It may not majorly point at resource availability, but that strong stance from the programs to say we need this data to come through. We've been able to give out some free commodities to a few private clinics, and we've been able to see them reporting because it is a condition. You need to account for what you've received, but we know that this is not sustainable. Some time to come, once we stop giving them the commodities, their reports will not come through. As I sum up, we've also tried to introduce the electronic community health information system. It's in pilot stage, but we know that this is an electronic version where UNICEF has supported to give some tablets and smartphones to VHTs. We should be able to see some data from FP coming through. So the way to go is to make the entire process more digital than manual, because private sector has moved ahead of us in terms of digitization. And so if you need to pick data, you don't have to introduce manual forms for them. Instead, see how you can tap into their already existing digital data and then fit into your reporting formats and be able to get this data. Okay. I conclude by commending the effort by Zimbabwe as well as Nigeria to have the data from the community as well as the private sector to come through. I believe the two presentations have provided great insights and provide also opportunities for cross-country level learning possibilities. Thank you.
Thank you, Rogers. Thank you very much. And now I'll go one more time back to you, Zenon, for just one last contribution quickly in maybe 2 minutes, focused on the community health worker dimension. To you.
Oui, peut-être une contribution de 2 minutes. Ce qu'il faut savoir, c'est nous avons un système tel que la prestation des agents de santé communautaire en planification familiale à profil non médical, c'est capté par les centres de santé ou les établissements de soins. Mais en parallèle, nous avons aussi les apprenants des écoles médicales, nursing school, et qui prestent et qui offrent un paquet beaucoup plus complet et qui ont un autre système qui ont une autre instance de DHS2 et leurs données ne passent pas par les établissements de soins et passent directement dans les DHS2. Voilà, merci Trinity.
Thank you for that. Again, another example of how complicated it can be to connect all of these different sources of data. And I think that that's why both the Nigeria and Zimbabwe examples are so interesting, because they're looking to pull all of those together. So thank you, Rogers. Thank you, Zenon. Thank you to Mr. Lawrence. And thank you to Brighton. So we will now, next slide, please, pass into our breakout group discussions. Next slide. Again, we're hoping that having listened to all of this very interesting information, we can now try to bring that together, share with each other, and really think about what the ideal indicators for monitoring the scale and reach of these two HIPs might be. Again, we know our starting point is quite open, but we'd like to think together about what information we want to collect, what information we think is essential for the national health information systems, and what some recommendations might be for obtaining that data. So many of you pre-selected your group in advance of today, and if so, you will be placed there. If you did not, you will randomly be placed in a group. So we will have groups that are talking about community health workers, groups that are talking about pharmacies and drug shops, and then one or two groups that are actually thinking about the gender and equity considerations and potential for using data to understand gender and equity as it relates to these two HIPs. Each group has a designated facilitator who will guide us through discussion, and a note taker who will be capturing discussion through a Google slide that we will use in our small groups. And each group should select someone to report out. And the facilitator will be able to let you know what specifically you will be reporting out on. It will just be one part of the discussion. And the note taker will be able to share their screen with your notes when we come back to plenary, so you'll have something to go off of. We're running a bit behind, but I would like to give us as much time as possible in our breakout groups. So we will go until 11:05. Actually, we're going to say 11:07 to be precise, to give us as much time as we can, but still allowed for some reporting out. So with that, we'll take a moment. You'll get assigned to your breakout rooms, and then we will come back. And for those who selected a French language breakout room or a Portuguese language breakout room, you will also be assigned to those. So Sarah, go ahead and assign us to our breakout rooms, and we'll come back at 11:07 my time. Thank you. All right, thank you, everyone. I know we're slowly reconvening in plenary. I hope that you all had good discussions. It probably felt insufficient, and that is okay, because I also hope you got to the last question, which was, where do we go from here? So we'll start our report outs now. I will kind of call on each of the groups and ask the note taker to start sharing the screen and the designated rapporteur to share the summary, fairly brief. We need to do this in about 3 minutes, so it's a brief summary for the particular question that you all are reporting out on. So I'll begin with the community health workers group that had Fred Makumbi as facilitator and Felicity as note taker. Felicity, perhaps you could share your screen and your designated rapporteur can go ahead and report out.
Hi, everyone. I'm the rapporteur for the CHW group. It's Ashley Wilkinson from Propel Adapt. As we're pulling up the slides, I think I'll just go ahead and start just summarizing the discussion. So two things that came out in the discussion about the presentations that were made. One was that there was some people mentioned that they were really struck by the number of different categories for CHWs, like some countries having 4 or 5 categories of community health workers. And also one other thing that really surprised some participants was the recognition of the role that the private sector can play in community health provision. So those were 2 things that came out of that discussion. In talking about what would be more desirable and feasible in terms of data collection, looking at the question of whether it's better to have the data collected all sort of collapsed and based at the facility, or whether it would be better to disaggregate the data to the different service points so that you could get a sense of how much service provision was happening at the community health workers, by private sector service points, for example. There seemed to be consensus that it was desirable to disaggregate by the service delivery point. And a few things emerged from that discussion about why that was important. So, for example, being able to see what contributions CHWs are making to FPUs in the community, and then also to help shine a light on potentially capacity building needs among the CHWs. And then also there was, again, a robust discussion about the role of private sector and how to integrate them into that data collection and disaggregating it to the private, the drug shops and other private facilities, and that there would need to be a way to keep it really simple and really boiling it down to just the most necessary data points, looking at digital solutions and also incentives for clients to be enrolled in that data collection process. So those were a few really good ideas that were surfaced. In terms of, sorry, are we out of time?
I might ask, so you've run through the first several discussion questions, which is great. I think I'm going to pass to the next CHW group to just report on the other ones.
Oh, sorry. Okay.
That's okay. No problem. Thank you. So then Sarah Brittingham and Barbara, so your group and the designated rapporteur, maybe you could pick it up from there and report out.
Yes, we have Jose Luis who's going to report out. Thanks.
Hello. So in our group, we share some experiences from Pakistan, Ethiopia, Suriname, and Colombia. We talk about the feasibility, for example, of the indicators. Should I talk about this slide specifically, or the whole discussion? Sorry.
Just slides 5 and 7, which Erica
Okay.
will show on the screen. Yeah, thank you.
So about this, the referrals, we propose that the best indicator should be the complete referral. So it would show the complete process, not just the process, like the partial process. Well, in some countries this is difficult. There is no coordination between the actors of the health system, NGOs and public facilities, for example. However, it is important to have to track the course of the access of this to the service. In this regard, it's important to have a national level approach to these indicators, precisely to understand the different points of contact of the user, of the client who is receiving the service or the family planning method. And about the disaggregation, it's important to understand the inequities within the countries at the subnational level. So it's important to show that people from certain ages, with certain ages, or in places at the rural or urban level in some subnational regions, for example, have less access than the others. Also about parity education of the person who received the referral. However, this is difficult. It is less feasible, it's desirable, but it's difficult to have it. And also the history regarding the previous use of family planning of a method. For example, if it's the first time that is referred, or had other episodes, other history before.
Thank you. Thank you so much. I'm sorry to jump in, but I think because we're running late, we're going to have to reduce the time for each of our report outs. So I will thank you very much for that. The good news is we recorded those and we do plan to synthesize this. But just for a little flavor of discussion, I'll turn to the Pharmacies and Drug Shops group with Rogers as facilitator and Sarah as note taker. If your rapporteur could, again, very briefly respond to one discussion point, that would be helpful. Thank you.
Thank you, Trinity. I'll invite Asmani, who is our rapporteur, to take us through. Over to you, Asmani.
Thank you. So again, understand due to time, so we discussed about what indicators, and before that we said generally it's very important. We thought this is a good source for, okay, where do we start? Okay, so we started about the relevance. And we all agreed that it is relevant to capture what the pharmacy and drug stores, the data from that, especially the fact that we have a lot of self-care initiatives where drugstores are the main source of the commodities. We said that we need to ensure only licensed ones, because ideally the non-licensed should be, should not be present. We also thought that when you talk about PDS, public and private are also important. And again, here, because of their role in self-care. We noted that it could be a challenge in terms of compliance and commitment of the private sector, lack of motivation, unless maybe they are part of a project. So that is some of the difficulties we thought when you deal with private, especially if they're not part of a project. And we said that it would be great if this could be mainstreamed into the general data collection. The type of data we thought about, or indicators, number of clients, method, age, and sex, number of sales by method, number of operators who've been trained, number of commodities distributed, number of clients referred for family planning from these, because they're also a source of referral, not only the service provision.
I think
yes,
I'll just stop you there. I'm so sorry to interrupt, Asmani. Thank you for selecting or for reporting back on what indicators within HMIS. So now I'm going to go over to one of the other pharmacy and drug shop groups and ask them to report on that second part outside of HMIS. What might we select? So Lara, looks like you're sharing. So that will be the group with Maria as facilitator. And I think Deb, you're up. Thank you.
Yeah. Can I just quickly though comment on the ones that we thought could be realistic for within the system? And let's just say we sort of had a different opinion that some of those indicators that the last group listed would be appropriate for like private clinics or hospitals, but smaller drug shops or pharmacies, we talked about how limited they are in collecting data, and that we would recommend things that would not involve the pharmacist having to ask personal questions of their clients, both because of the difficulty and then also the discomfort from both ends of the pharmacist asking those kinds of questions when that's not what they do at all. So limiting that to more like number of commodities sold or number of sales, like that was overlap with the group, data on stockouts, and then also potentially like in countries where self-injection is being rolled out, the number of injections being done by the pharmacists themselves versus how many they're giving to the client, presumably for the client to self-inject at home, like that could be important. But again, it's kind of it does not involve asking the client for anything, which puts the pharmacist in a very different role than they currently are. And that would have to be in terms of data outside the system. We talked about how surveys are really not a great source of this kind of information. We talked about possible occasional data collection, like extracting data from maybe if there's client forms that are filled out, or even talking to clients, like doing quick surveys. And just because it's occasional doesn't mean it can't be routine. I mean, you could routinely on a regular basis do it. It just would have to be very infrequent and you'd have to somehow select. But like that kind of information would be useful, but we didn't have any other, my group, speak up if you have ideas, but yeah. And we talked a lot about like motivating factors of how to get routine data, both carrot and stick that can be used, but yeah, I won't go into all that. Thank you.
Yeah. Thank you so much, Deb. Appreciate it. And I'm sorry to the third group because of time. I think we need to jump over to the last group, which we're focused on thinking about gender and equity dimensions of these particular HIPs and how those could be captured. So I'll ask the group that had Nike as facilitator and Allison as note taker, if you all would just share back some of your discussion points.
Yeah, so Alison will be doing the report back.
Yeah, thanks. Can you all see my notes here?
We can.
And hear me. Okay, great. So my group can feel free to compliment, but we had a really robust discussion and I'm sharing out on this last question. So our group, again, was a little bit of a different assignment in that we were looking across the two HIPs, the community health worker and pharmacy and drug shop HIPs, to see if some of the routine indicators for monitoring could capture gender and equity considerations in terms of empowerment and agency and decision-making power, and then male involvement, for example, and then in terms of equity considerations, differences in access and use. So I bolded a couple of things I thought might be helpful to highlight for the pharmacy and drug shops indicators. We were getting a little creative because this mostly is not available in the national HMISs. So surveys would be a good source for some of this, we thought. Autonomy and agency indicators can come from the DHS in many countries. We discussed there's a composite indicator, for example, that looks at whether the decision to take up FP is made jointly with a partner, another aspect of that indicator is whether there's any sexual coercion. And then just noted that the DHS is conducted sometimes only every 5 years, depending on the country. So there's some limitations, of course. Quality of service indicators can be obtained through client exit interviews for this area as well. And disability status, we discussed a lot, typically not collected again through HMIS, but there are indicators in DHS in several contexts and health facility surveys. And then we discussed, just skipping down a bit, there are a number of partners who are actively engaging in this area that we can, learn from, notably Marie Stopes and IPPF. Our group was lucky to have a number of folks from Nigeria, UNFPA Nigeria partners with PPFN, the member affiliate in Nigeria, and they do prioritize access to family planning of persons with disabilities and also people in humanitarian context, which is another equity population that we were discussing. Those are the highlights. Thanks.
Thank you. Thanks to that group as well. And again, I'm sorry, but given the time, we won't hear from the last group. But I do know that that's a whirlwind, both of topics to discuss in small groups and of an attempt to report out. So I thank you all for your efforts with that. Emily, if we can bring back the slides. Again, it may feel like loose ends. I know I'm interested in hearing people's thoughts on how to carry this forward, which was sort of the last question that we had, and ideas on groups or platforms that would be good choices for trying to continue to advance this discussion. So we'll look forward to digesting those further. But given the time, I'm going to just hand it over to our final speaker providing closing remarks, Erica Locken, a senior program officer at the Bill and Melinda Gates Foundation. So Erica, I invite you to come on and close us out.
Great. Thank you, Trinity. Hi, everyone. Good morning, afternoon, and evening. I joined the Gates Foundation at the end of last year and have had the pleasure of working with Orally, Trinity, and the rest of the FHI 360 team over the last few months. The motivation behind the Gates Foundation support for harmonizing measurement approaches and standardized indicators for family planning HIPs comes from both our data team, where I sit, and also our global partnerships team. So our hope with this convening and related projects that we've funded in this space over the years is identification of critical gaps in evidence, indicators, and guidance that can facilitate adoption and scaling of HIPs, as well as overall support of data-informed decision-making. So I just wanted to share a few sort of points that stuck with me from the rich presentations and conversations over the last 2 days. The convening opened with a bit of a history lesson from Jason Bremner around the fact that conversations around standardized measurement for the HIPs have been ongoing for some number of years, particularly for PPFP and PAFP, and less so for community health workers and the pharmacies and the drug shops. This work has progressed with each project and convening and with all of the cross-country, cross-stakeholder learnings and sharings. I appreciated the comment from Priya from Track 20 yesterday about how sometimes it's less that there's a lack of consensus in these indicators and reporting across countries, and rather that the differences really reflect that choices are often driven by differing country priorities, incentives, and resources. Today, I really enjoyed hearing from Brighton about the work in Zimbabwe to capture data from the private sector, where nearly a quarter of women are accessing their family planning, and also from Mr. Lawrence on the work piloting the CHW HMIS system. Both were really great reminders that we can't talk about measurement and indicators without thinking about the data systems that support it. And just generally, I heard a lot of enthusiasm overall for improving and expanding measurement. And at the same time, there was a recognition that while we want to measure everything, I think Olenike this morning called this the dream, it's not feasible or always actionable. So it's really a challenge to kind of balance these two sides. So thank you to everyone who joined today and yesterday, to all of the presenters, to the translation team, to all of the stakeholders who've been engaged through data collection processes across the various projects reported over the last 2 days. And lastly, to Orally, Trinity, Elena, and the full planning committee who brought us all together over the last 2 days. So I look forward to seeing you all at the next HIPs measurement convening coming up this summer. And we'll just say stay tuned for more on how to remain engaged in this work. Over to you, Trinity.
Thank you, Erica. I really appreciate those closing remarks. I also want to acknowledge another group that I forgot to call on due to time constraints. So our French language group was also engaging with these important topics, and we will again have that record to synthesize. And as Erica said, we will keep you all updated about how to stay engaged. We'll be in touch also to share, of course, the PowerPoints, the recordings, and some other related documents. So thank you all so much for your time. Really appreciate it and look forward to staying engaged. Happy day.